See. Um, 1 second. Let me pull this chat if I can. I can't see the chat, so if there's questions, can someone just stop me?
Yeah, for sure. I'll monitor the chat for you.
All right, sounds good. So welcome everybody. This is I don't know what lecture number it is in my clinical approach to series. This is going to be a clinical approach to shock from the med student's point of view for emergency medicine and for your ICU rotations. Um, oh, I can't click it. Okay, so a little bit of shock overview. It's basically a circulatory collapse that leads to tissue hypoxia and poor organ perfusion. It's a fundamental knowledge set to have in emergency medicine because anything can walk through the door and you need to know how to handle it, how to recognize it. Um, 4 types of shock: cardiogenic, distributive, obstructive, and hypovolemic. Um, Early recognition leads to better outcomes and improves patient morbid and mortality. And we're going to talk a little bit how we manage and treat shock, depending on what type of shock is going on. And then at the end, I'm going to kind of hone in on sepsis and septic shock because it's easy to assess a student's knowledge in shock overall. And it's something that you're going to see as a student, the residency, and as an attending because hospitals are going to bark down your throat about it. And you're going to see it in the ED and in the ICU setting. Um, so that being said, kind of the need to go to the basics a little bit. If you can understand what's going on in this slide here for board exams and for the clinical applications, you'll be able to answer questions a lot quicker and more correct, and then know how and why we treat shock patients the way we do. And if you see here, MAP is basically equal to the cardiac output times the systemic vascular resistance. And that basically just means if MAP is a constant number as like 70, if cardiac output goes up, SVR has to come down and vice versa. And then cardiac output is further defined as heart rate times the stroke volume. And all this is saying that is the exact same thing, but some things to note is as heart rate increases, diastole has to shorten, which would decrease the stroke volume. Um, but that's like at a rate of like 160, 170. But stroke volume is also more influenced by the preload and afterload, but it's more influenced by preload. And if you understand these two equations and the relationship that's going involved, you'll understand what's happening in each shock. And then when you get the diagrams of like the up and down arrows and all that fancy stuff that we love as test questions, you'll be able to understand and answer the questions faster. So first type of shock we'll talk about is hypovolemic shock. You can just think of this in terms of the patient being volume down across the board. And you have 2 types of hypovolemic shock. You have hemorrhagic versus non-hemorrhagic hypovolemic shock. Things that kind of lead to this is any type of GI bleed or acute blood loss by way of like trauma. Think of like open book pelvic fractures that lead to massive internal bleeding. Third spacing by way of severe cirrhosis or severe CHF. These patients can be easily intravascularly depleted, which can lead to hypovolemic shock, even though on physical exam you see ascites and like lower extremity edema. And fluid losses, so burns are a big one, GI or renal losses. Physical exam, it's going to be pretty standard across the board, but for hypovolemic shock or hypovolemia, you'll see dry mucous membranes and decreased skin turgor, as well as cold and clammy extremities and non-distended jugular veins. And the treatment here is obviously to volume, resuscitate, provide blood transfusion if needed, and achieve hemostasis by some manner. The parameters of shock, if you think of it as complete volume down, by definition, the preload is also down. So then as going back to those equations, you can expect the parameters for cardiac output to go down, CVP, which is a surrogate for the right atrial pressure, to go down, the pulm capillary wedge pressure, which is a surrogate for the left atrial pressure, that has to go down as well. And as a result, the SVR or the TPR, they go up, and heart rate also goes up as well. In obstructive shock, it's basically anything that impairs the right ventricle during diastole to fill, resulting in a decreased cardiac output. And the three classic ones you'll be tested on shelf and other board exams is pneumothorax of any kind, but like most specifically attention pneumothorax, pulmonary embolus, saddle, or a segmental PE, and cardiac tamponade. Physical exam is cold, clammy extremities. You'll have JVD here, and you'll either have decreased or absent breath sounds, distant or absent heart sounds, maybe tracheal deviation. Treatment here is fluid resuscitation, and obviously to relieve the obstruction by way of like pericardiocentesis or needle decompression. And it may not be intuitive to flush them with fluids and pump fluids into them. But if you can think about, say, like tamponade, basically the pericardial sac fills up with fluid, right? And that massive increase in change in pressure will collapse all of the chambers. And that's what's impeding the right ventricle from filling. So if you flood them with fluids, you're forcing the chambers open, and then that buys you some time until you can or like take out the pressure or relieve the obstruction. So that's the whole reason if you get asked that because attendings will ask you that. What to expect in obstructive shock in terms of the parameters? Obviously, cardiac output, it decreases. CVP will go up because nothing can get into the right side of the heart. Depending on what type of obstruction, pulmonary capillary wedge pressure can stay the same. Mostly, you're going to see a decrease, and SVR and heart rate has to increase as well. In cardiogenic shock, this is a pretty easy one to understand. It's basically the heart's inability to maintain an adequate cardiac output. There's many etiologies behind cardiogenic shock. Some of the ones you'll be tested on and you'll be asked about are myocardial infarction, ACS, arrhythmias are very famous for doing it, valvulopathies, and toxic exposures. Again, the physical exam signs here is they're cold and clammy, elevated jugular venous pressure, signs and symptoms of heart failure, maybe palpitations, maybe they're syncopizing or they have a new murmur. Cardiogenic shock's treatment in general is fluids after you do a fluid challenge, kind of assessing volume status. And then, of course, hemodynamic support by way of inotropics or vasopressors and diuretics as well. And the parameters here are obviously the cardiac output decreases, but everything backed up has to increase as well. So pulmonary capillary wedge pressure and the CVP both increase. SVR increases because cardiac output goes down. And the heart rate here can be a bit variable depending on what's causing the shock. So just keep that in mind. It may not always be up or normal or down. It can be variable. Now, the most complicated type of shock to talk about is distributed because there's multiple subsections of shock within the category. Basically, it's a vasodilation with or without capillary leakage leading to redistribution of fluids from the intravascular space to the extravascular space. And the etiologies here are sepsis or septic shock, anaphylactic shock, neurogenic shock, and acute adrenal insufficiency. And on physical exam for sepsis, early sepsis, you'll see flushed and warm skin. That's due to the vasodilation. And then late sepsis, you'll see cold and clammy. And it's because peripherally now you have vasoconstriction to keep the major organs perfused. Findings, you'll see findings of SIRS and maybe an underlying infection type symptoms, fever, chills, coughing, that kind of thing. Anaphylactic shock, you'll hear or see a confirmed allergen exposure, and you'll see urticaria, abdominal pain, hypotension, and or shortness of breath or chest pain. And it needs to be known that in anaphylaxis that precedes shock, you can have one of the four. You don't need all four. So to keep that in the back of your mind when you're on your rotation, if you're concerned for anaphylaxis of some sort, because it is a medical emergency, they can have one of the four here present, and it should send alarms off in your head. And then neurogenic shock, which is again flushed and warm skin due to vasodilation. But the caveat here is that you have hypotension and bradycardia. And again, this is more specific to like trauma. So if you have trauma and a neck injury or some type of back injury, you can see neurogenic shock. Other than that, it's not really all that common to see outside of trauma. But in a board question, if you see hypotension, bradycardia, it's almost always neurogenic. So the parameters of septic shock and anaphylactic shock are pretty much the same. Cardiac output mostly decreases, but it can also increase. CVP decreases. Same with the pulmonary capillary wedge pressure, and SVR actually decreases as well. That's because of the vasodilation, and then the heart rate increases as a result. Neurogenic shock is the same, except the heart rate again it decreases, and I bolded it here because that's how you distinguish it between the other two types of distributive shock. So in the undifferentiated shock, how do I know? And then now I want to ask you guys, how will you diagnose shock of any kind? Like, is there any one thing, or how like will you go grab your attending and tell them why you think it's shock?
I mean, I would start with, vital signs and like how they present. Like, are they cold and clammy? Are they warm? Like, I would start with those things and be like, wait, there's something wrong. Like, what do I need? What are my next steps from here?
Yeah, so shock in general is a clinical diagnosis. All the types of shocks are a clinical diagnosis, and I cannot stress that enough. You do not need lactates, you do not need anything else to diagnose it. You need it's just a clinical type of thing. The where you get into the diagnostics is treating a specific type of shock or finding out like what's actually going on. But based on how the patient presents to you, based on like you said, their vital signs and your physical exam, you can make a diagnosis of shock. And we'll kind of go through that here in a few slides. It's good to note here that not all patients will present with hypotension. The two caveats here are early sepsis. People may have normal pressures, and chronically hypertensive patients. These patients also can have normal pressures but be in shock. So it's just something to keep in the back of your head. Vital signs in general, blood pressure will be decreased, heart rate and respiratory rate will both be increased as well. And then again, more clinical objective findings like on physical exam of shock in terms of end organ damage. Neuro, they'll have altered mental status, agitation, lethargy, or coma. In terms of renal, they'll have oliguria. I bolded here less than 0.5 cc's per kg per hour of urine output because that's the bare minimum. And I would know that for your IM rotation, ED rotation, and ICU rotation because you will get asked about it. It's very important to know that. And then of course your skin findings can be kind of all over the place depending on what's going on. So like decreased or normal capillary refill, cold or mottled, or maybe they're warm and flushed. So yeah. So now in terms of the diagnostics in the workup for undifferentiated shock, or maybe you are going down a specific type of shock. For global hypoperfusion, you'll grab a lactate and you'll get an ABG. Lactate's obviously going to tell you if there's some type of anaerobic process going on, and ABG will let you know if there's an acidosis, and or if there's any type of like contraction alkalosis that you can kind of see early on. CBC, CMP, you'll suggest this to your resident or attending. In terms of the hemoglobin and hematocrit, I bolded this too because this will show up on, this is a URL question, it'll show up on STEP. And in clinical practice, you need to know that the first in hemorrhagic hypovolemic shock or any type of hemorrhage in general, you're only going to see a change in the hemoglobin and hematocrit after you give fluids. So the first set that you do, if someone comes in with a GI bleed, you don't just not get O neg blood. Like you get it and have it at the bedside, because what's going to happen is they'll have a hemoglobin of 10, you give them fluids, and then now they have a hemoglobin of 5. Now you're just wasting time. They're actually truly acutely anemic. Renal function, things like you want to identify AKIs and know how to treat it, and also as the baseline function. LFTs will let you know if there's any shock liver going on, because you can see that a lot in hypovolemic shock and septic shock. A coag panel, because the more intravascularly depleted that you are, the more the higher percent chance you have of the clotting cascade being activated, and it can precipitate DIC. Troponins, because again, it's a marker for end organ damage of the heart. Septic workup, which is a chest X-ray, blood culture, urine culture. I'd actually know that in case you get asked, because that's an easy pimp question. EKG to assess any arrhythmia or any type of moderate ischemia that might be going on. And of course, chest X-ray here is specifically looking for anything like a pneumonia, pulmonary edema, or a pneumothorax. I say this in almost all my lectures. Ultrasound and POCUS are becoming like the standard of care for almost everything. And if your patient comes in acutely ill, you're gonna want to obviously like talk to the patient, family, EMS, and all that stuff at the same time. You'll do POCUS to kind of get a rapid assessment. And this particular exam is called the rush exam or the rapid ultrasound for shock and hypotension. And all it is basically the fast exam plus a couple extra steps. So here you'll look at both lung fields. Mostly you're looking for any pneumothorax. And then you're looking at the pericardial views for any type of pericardial effusion or any valve issues that might be going on. You'll do the fast exam, and then you'll lay eyes on the IVC and the aorta if there's an aortic dissection going on, or the IVC. The IVC part of the exam is the most probably critical for you to actually like kind of know, and because it'll tell you the volume status of the patient in real time. And then of course you're still going to look at the bladder, and I would say for females too, if you're concerned for a ruptured ectopic, to kind of get a quick scan of any of the transabdominal pelvic organs, because you don't want to miss a ruptured ectopic and then like just a delayed care to the OB. Yeah, so it's called a rush exam, and I would know it. I would be asked about it, and kind of how to perform it too. So the management of the shock is very complex. You can do multiple different lectures on it, but basically it's based on the type of shock that's occurring. You take an A, B, C, D, E approach, which is basically airway, breathing, circulation, disability, and exposure. In general, you want 2 large bore IVs, central line or IO access. In cardiogenic shock, you can give fluids, but you have to assess fluid responsiveness, because you don't want to make it worse. Fluids in adults, you typically could do a 500 to 1 liter, or 500 cc's rather, to a 1 liter bolus of fluids. And in peds, everything's weight based. And I would definitely know this, because I have been asked by residents. It's 10 to 20 cc's per kg bolus, but not to exceed 45 cc's in the first 3 hours. And you'll want to know that because when you admit these patients, you have to tell the attending or the resident how much fluid you actually gave. In terms of airway support, all patients should receive supplemental O2 to prevent or correct a hypoxemia. Advanced airways are indicated for airway protection or the need for mechanical ventilation. But just be known, or just know that there's a risk of mechanical ventilation around the peri-intubation window in volume compromised patients. And it becomes an art as to when you intubate your hypovolemic patients. And the reason is because they're already volume down and preload dependent, and they're already hypotensive. So outside of the sedatives that you give for intubating, and you'll drop their pressure even more, when you put them on mechanical ventilation, what happens is in a normal inspiratory drive, you have negative intrathoracic pressure. So it pulls blood from the IVC and it fills the right ventricle, increases preload, decreases the right ventricular afterload. When you mechanically intubate them, they have positive airway pressure. And so this basically doesn't have that pulling effect from the IVC. It pushes blood away from the right ventricle. So it decreases preload and increases the afterload, and you can further have cardiovascular collapse. So it's very important that you fluid resuscitate before you intubate. I would know that too. More hemodynamic support are vasopressors. There are three types. You have the enoconstrictors, the pure vasoconstrictors, and the inotropes. In terms of enoconstrictors, the one you're probably always going to say is norepi, at a rate of 0 to 40 micrograms per minute. It has alpha 1 and beta 1 activity. The others are epi and dopamine. The pure vasoconstrictors are vasopressin at 0.03 units per minute. It's a standard dose. There's no up and down. And phenylephrine. And then in terms of the inotropes, you have dobutamine and milrinone. And of the ones on this list, again, you'll never be wrong if you say any of these. You'd be more correct if you say norepi for any type of shock. I will say phenylephrine is probably the most wrong answer if you had to give one. It's a bad vasopressor only used in very specific scenarios. And in terms of like cardiogenic shock, you can also use norepi and then like be fancy and say milrinone because it actually shows a lot of benefit. Yeah. So in terms of sepsis and septic shock now, um, I would actually know this again because it can be asked from any resident or attending in the ED and the ICU. Outside of hemorrhagic or hypervolemic shock in the ED, it's going to be one of the most common types of shocks you actually have to deal with. There's two ways to risk stratify your patients, and by way of SIRS or the Q-SOFA. If your institute uses the Q-SOFA, you need two or more of the following. So a respiratory rate of greater than 22, altered mental status, and a systolic blood pressure of less than 100. I will say that not many facilities use this. They go back and forth in the literature between Q-SOFA and SIRS. So it's really dependent on how you want to actually stratify the patient. But in general, most people still use SIRS because that's what's comfortable. And SIRS is basically two or more of the following: a temperature of greater than 38 degrees Celsius or less than 36, heart rate above 90, respiratory rate above 20, or a PaCO2 of less than 32, and a white blood cell count of greater than 12,000 or less than 4,000, or 10% or more bands. And then there's different levels of sepsis. So SIRS positive is, like I said, two or more of the criteria. Sepsis is the above plus a confirmed source. So pyelo, UTI, pneumonia. Severe sepsis is sepsis and at least one sign of end organ dysfunction. So sepsis plus oliguria is severe sepsis. And then MODS is multi-organ dysfunction syndrome, which is basically sepsis and your body is shutting down. So yeah. Identifying sepsis, again, is a key to improving patient mortality and morbidity. And as I said, the etiology to this is any type of bacterial infection, pneumonia, UTIs, pyelo. And the first steps here is what you'll hear as a 1 hour bundle. And you'll take the same A, B, C, D, E approach. You'll get some type of vascular access by way of 2 large bore IVs, maybe a regular peripheral IV of some sort, an IO or a central line. But You of course want to attach the patient to the monitor, assess blood pressure. If they're like hypotensive, you want to keep their MAP around 65, uh, with or without vasopressors as needed. Um, Now part of the actual 1 hour bundle is 30 cc per kg bolus in the first 3 hours. It's very important. Starting them on broad spectrum antibiotics, grabbing a lactate level and a blood culture. That's like what you have to do. That's the metric that hospitals use in treating, in one, identifying and treating sepsis, and it's a whole ordeal around like numbers and reimbursements and all that kind of thing. Then after all that, you'll get the other labs and diagnostics, your troponins, EKG, chest X-ray, urine with culture, CBC, CMP, coags, all that kind of thing. And again, like you're looking for end organ damage, so AKI, you can have a type 2 STEMI, elevated LFTs, DIC, as just examples. And then the key cornerstone to shock is blood pressure management, or MAP management. And you want to monitor somehow, but in general, if it's shock, you want to do invasive monitoring by way of an art line. And the goal is to keep the MAP around 65. And in terms of vasopressors for septic shock, per the Surviving Sepsis Campaign guidelines, that I'm sure some people have already been asked to read multiple times, the first line is norepi. It's always the right answer. You just say norepi and you'll be fine. Then if they're still hypotensive or like their MAP's not quite 65 yet, the second line is to add on vasopressin and then kind of reassess again. If MAP is not controlled or not at 65 or around 65 on a low to moderate dose with vasopressin, then you can add on epinephrine. And if that's not working, the fourth line, you can consider adding dobutamine or switching entirely to epinephrine alone, per the new guidelines out. And as an adjunct, you can consider adding corticosteroids early in septic shock and also for ARDS and CAP. This is actually a brand new change that came a few months ago, actually, to the Surviving Sepsis Campaign. And it's actually a actual recommendation to add on steroids early. So maybe after norepi, but also maybe after vasopressin. If you suggest this in the ICU or maybe in the ED, you're just gonna look like a star because this is like new guideline stuff. And then you'll also be asked when you want to de-escalate vasopressors, and it's in the order that it was added. So keep that in mind. In terms of images, here's what the ultrasound of the IVC looks like in a normal IVC. You can see here it looks pretty well open. Upon inspiration, it kind of collapses, but you can kind of still see some blackness in there, some fluid on both sides and in the middle. This is a normal IVC on ultrasound. This is, and obviously it's abnormal, and the large picture on the left is an obvious picture of what a massively dilated IVC looks like. Again, here you want to think of PE, heart failure, tamponade, pneumothorax. And then on the right side, you can see that that IVC is completely collapsed. And both walls of the lumen are touching basically. And this is things like hypovolemia or sepsis. Uh, Anybody want to tell me what's happening in this picture? What's the first thing that popped in their mind?
Cardiac tamponade.
Yeah, so pretty much what's happening here is a pericardial effusion that can lead to tamponade. And it's why the rush exam or ultrasound is so important in being used nowadays, and why we're seeing an increase in training and the emphasis on ultrasound training in residency. It's because if you see this and then signs of shock, you can start treating it. You can call cardiology, get them to the cath lab, etc. So, yeah. So here, I don't know if you guys can see my arrow, but in this blackness, this darkness here, this is a bunch of fluid. And up in here, and you can already see the right ventricle is already being small, and this is the left ventricle here. So this is a this is a very big problem going on here. And this is the personal lung axis view. Uh, can anybody tell me what's happening in this chest X-ray?
A pneumothorax.
Right. So here on the right side, it's a giant pneumo. This is what it looks like. It looks obviously not aerated as the left side does. This is the various obvious pneumothorax. Some might not be so obvious. But yeah, you see this. Typically, you want to needle decompress if like there's tracheal deviation, or you'll want to throw a chest tube in to help out with this pneumothorax. And can anybody tell me what's happening in this picture?
Looks like a wide mediastinum dissection.
So there's no dissection going on in this picture. I threw it up here to point out another pneumothorax. You can see it down here in the right costophrenic angle, and this is what's called deep sulcus sign. And you can have patients that have a pneumothorax, but because of the way they're laying when a particular chest X-ray is being taken, the way gravity works, air can escape down into the deep sulcus. So if you see a deep sulcus sign, it's a pneumothorax. And then these patients have to be sent through the CAT scanner to see like more specifically what's going on. Just wanted to throw it in there and mention it because I've seen this on rotation a couple of times. And these are my sources for how I did this presentation. I'm pretty much done.
That was awesome, Jared. Thank you so much.
You're welcome.
Does anybody have any questions? Okay. If there's any questions, if everyone could please fill out the sign-in form, I'll put it one more time in the chat. This will just help us to gauge attendance. And then also if you guys want to do like have suggestions for topics or anything that you would like to see, please put that in the last comment on the sign-in sheet, and we would really appreciate it.